Our last speaker, Professor Bogdan Bube from Romania. His talk will be about transarterial chemoembolization with drug-eluting beads, clinical experience, and follow-up.
Okay. Ladies and gentlemen, my talk is about my experience and the follow-up in liver tumors treated by liver chemoembolizations with DC beads, with tandem microspheres, so generally speaking about particles loaded with drugs. Okay, moving to the point. We know very well that the hepatic metastasis on the colorectal cancer occurred in approximately 60% of all colorectal cancer patients. On another hand, the HCC is one of the major cause of cancer death. I'm not sure if we can see very clear the... Oh, okay, very good. Discussing about this and going to the point. Liver malignant tumor sources. They are primary and they are secondary. Primary, secondary are originated in the liver, and it is a heterogeneous group of tumors. It could be nodular infiltrative. There are very different histological types of tumors with alpha-fetoprotein positive or not. On the other hand, there are secondary or metastatic lesions that are spread to the liver, and mainly these belong to the colorectal cancer, but not only, about breast cancer, lung cancer, and from neuroendocrine tumors. Interventional oncology certainly is based on the dual blood supply, you know, all of them, that the portoven supplies the normal liver. Beside this, the HCC and liver meds are supplied by hepatic artery. Why should we perform targeted liver chemoembolizations? The principle is very easy. We have here colored in red the distribution of the drug. In fact, in this case, it's about doxorubicin. The distribution in all the body with a systemic chemotherapy. In the second case, it's here. We can see still the distribution in the abdominal and pelvic area, but if we use targeted particles, the distribution will be only in the liver. In completion with this, I can show you a slide. It was proved by experimental work that in 6 hours after we inject the microspheres into the tumor, the concentration of the drug, of doxorubicin, in peripheral blood is 0. How could we perform the diagnosis? Diagnosis is made via a combination of tests, like serum markers, like liver function tests, enzymes, and imaging. Imaging is very important. The most important of them, I should say, is the CT scan and MRI. Certainly for us, the most important class of, let's say, of the patient is the patient with child A and child B. Besides this, there are many guidelines. Another guideline should be the guideline from American Association for Study of the Liver Disease. But certainly the Barcelona guidelines are very important, and if related to this, we should treat the patient for intermediary stage. It's exactly like this. Next stage, the advanced stage, is very well treated with sorafenib. Discussing about the follow-up procedure. We use the response criteria according to the European Association for the Study of the Liver criteria in order to assess the necrosis. On another hand, we must assess the size of the tumor in 1 dimension or 2 dimensions. So in this case, we use RECIST criteria or modified RECIST criteria. Discussing about the protocol. You can't obtain good results if you are too fast in injection. I think the slow injection is a very important point. If you want to inject in 5 or 7 minutes, all the microspheres loaded with doxorubicin or irinotecan, everything will be fine. But if you perform an angiogram after 15 minutes, you will see half a tumor, it's still well vascularized. There are some rules of chemoembolizations. Embolization decreases the tumoral vascular bed. We know, all of us, we know this. Sensing hypoxia, cancer cells stimulate angiogenesis. Ischemia induced by TAC contributes to the formation of new vessels. So it's not our goal to go for ischemia. We need to perform, in this case, anoxia in order to destroy the tumor. It's also important to have, it's very important to have, to have the angiogram before we perform the intervention. Why? Because, as you know, one of the cause of, let's say, the react we don't expect, a bad result, for example, let's say, are the collaterals. We must identify the collaterals which could supply the artery before chemoembolization. In some cases, we can use the dual system angio-CT, like here. In some cases, we can use, in very good conditions, the cone beam CT. If they are not available, I strongly recommend to use the pre-intervention angio-CT or angio-MRI, like I did before in these cases, in order to see very well which are the feeding arteries and to treat all of them. Otherwise, we will see there are extrahepatic collateral arteries, there are 12 extrahepatic collateral arteries, and if we miss one of them, we will have a bad result. There are some eligibility criteria for tandem particles chemoembolizations, like no previous radiotherapy or transarterial embolizations, a confirmed diagnosis of HCC, or a child poor class A or B or ACOG status 0 or 1. Patients should be excluded if they've had another primary tumor or with a patient with advanced liver disease, bilirubin more than 3, for example. Advanced tumoral disease, diffuse HCC defined as more than 50% liver involvement, after another authors more than 70% percentage, and or contraindications for doxorubicin administration. Here I showed how we mix the particles. We use a machine. The particles are mixed for 1 hour. Certainly we can do this manually, but it's better doing this. It's very important to have a clear supernatant here. So in this case, it's not a good mixing, it's not enough, this mix. In this case, it's much better mixed. It's very important to load very correctly. The response is proportional to this. After that, I think we assess the response. The complete response means the disappearance of any intratumoral arterial enhancement in all targeted lesions. Let's see some images. HCC, one lesion HCC, in this case in the right lobe. There are two patients here, and here after the first session of drug-eluting big TAC, we see a big area of necrosis. It's an intermediate result. Here is another patient, and we can see here also in venous phase the necrosis. Another patient. It's a patient was done in January 2012. After 2 sessions, we obtained necrosis, and this is the result after 3 years, more than 3 years. Even on the PET-CT, they couldn't find the activity, tumoral activity. Very rare, very rare, we perform a conversion from conventional TAC to chemoembolizations with microspheres, especially if there are cases that we didn't have any response, a good response in conventional TAC. Another case with a large HCC treated by 2 sessions of liver chemoembolizations, and we can see the necrosis very well. And another cases, it's also an ACC. This is the lesion before drug-eluting big chemoembolizations, but this is the evaluation after almost 1 year. Certainly, we face with in other cases, worst cases with like multifocal HCC in both lobes. In this case, we perform 4 sessions in the period of from 2 to 2 weeks, so totally 2 months is the treatment. Like in this case, where we can see islands of tumors in both lobes, right and left lobe. We treat it, as I mentioned before, by 4 sessions of chemoembolizations, and this is the response where we can obtain different grades of necrosis in all the lesions. Going and moving forward to the second part of my lecture, we should say that many colorectal metastases are hypervascularized. In general, colorectal metastasis has less vascularity with fine tumor feeding arteries in contrast to hepatocellular carcinoma, but still many are hypervascularized from hepatic arteries certainly. Theoretically, a large number of small-sized drug-eluting microspheres could penetrate deeply into peripheral tumor vessels and completely occlude the fine feeders with effective eluting drug coverage. In this case, we use microspheres loaded with irinotecan. Patient with liver metastasis has a poor prognosis, generally speaking. The active form of irinotecan, we know, is SN38, is released into the tumoral tissue. It were some results of the Biri. It were done in 2000. It was published in 2009. Transarterial chemoembolization using drug-eluting microsphere loaded with irinotecan was first reported in 2007. In 2012, Selonova developed embozentan microspheres, which are now the particles of 40 microns, the smallest size. I want just to mention the conclusion of the study published by Professor Fiorentini in 2012, that the median survival was around 22 months for the Biri and 15 months for FIRI. Dual therapy is very important. So patient presenting with initial unresectable colorectal metastasis, either by a number of lesions or extrahepatic metastatic disease, have the benefit of systemic 5-fluorouracil-based chemotherapy with a combination of oxaliplatin and or irinotecan. This is just to mention a study and experimental work done by Dr. Tanaka from Nara from Japan. He divided rabbits in 3 groups. First group full-loaded irinotecan, that means 100 milligrams, high-dose injection. The second group full-loaded irinotecan, low-dose injection, that means half injection. And the third one, half-loaded irinotecan and high-dose injection. Which were the conclusions? Histological findings showed microspheres had deeply penetrated into tumors. We can see them with arrows, especially in group 1 and 3. So drug release with high concentration in tumors can be provided with 40 microns microsphere, even we reduce the dose of irinotecan loaded. We can see here a very important thing, that the number of microspheres is in correlation with their size. As smaller is the size, for example, we can see at 40, we can see that as bigger is the number of the microspheres distributed in 1 milliliter. The number is, for example, is increasing from 100 microns, 1.7 millions, to 21 millions. So this is very important. The size is very important. Also, we can compare, because I work with DCBs and I work with tandem, we can compare both of them. Tight calibration also is very important, because tight size calibration decreases the risk of premature vessel occlusion. Okay, moving forward to some images, I can show you some images. For example, firstly, one lesion, colorectal metastasis. This is a lesion. Here we can see also some calcifications. The patient received before polychemotherapy, 1 year before polychemotherapy with good result. And another case, one colorectal metastasis. The patient has also C virus, but it was biopsied tumor and it was a colorectal metastasis. We used tandem 40 microns and irinotecan 100 milligrams. We saw here, and we can see after the first session, the necrosis still appears, and after the second session, the necrosis is completed. Another case, colorectal metastasis, more than 2 lesions, 1 lobe affected, or another situation when there are both lobes affected. Certainly, we use in this moment the same amount of 100 milligrams loaded in 40 microns microspheres. And we evaluate the response regarding not only the size, but also, like it's shown here, the grade of necrosis. Even we discuss about the patients with metastatic lesions in both lobes, right? And like it's shown here. Sometimes we face with technical difficulties, certainly increasing time procedure, and it's more difficult to arrive in the suitable point in order to dispatch all the microspheres. I don't want to underline because this slide, because it was some talks before regarding the treatment of sorafenib, but anyway, I want to tell just even some studies are very clear. It is still a heterogeneity of this published studied. The conclusion of one of them says the control rate of disease if we perform the drug-eluting bead chemoembolization and in the same time the treatment with sorafenib is 95%, and the objective response is almost 60%. Okay, there are certainly some contraindications to liver chemoembolization, like decompensating cirrhosis, like jaundice, like extensive tumor, like severe reduced portal vein flow, renal insufficiency. I want to underline that the relative contraindications considered by most of the authors, is the tumor size more than 10 centimeters. Discussing also about the complications, the most important complication is post-embolization syndrome, like pain, nausea, vomiting. There are another complications like hemorrhage, liver abscess, acute hepatic decompensations, cholecystitis, pancreatitis. All of them are mainly related to the techniques. And they could be solved by conservative treatment. In my experience, I figured here only the most important complication, let's say the pain, is colored in blue. So it is a big difference regarding this pain in using DC beads and tandem microspheres. In the favor of tandem microspheres, certainly. Okay, I want to conclude, certainly. So the take-home points should be: the dimension of microspheres is the future, the smaller the better. Multidisciplinary management and HCC and meds from colorectal become far more complex and collaborative in the optimal treatment of patients with metastatic colorectal cancer. We should work in a team. The chemoembolization with the drug-eluting beads is safe and effective treatment. There are a multiplicity of diagnosis criteria. All these criteria means none of them are completely satisfactory. The STORM trial said that up to now, only sorafenib is an efficient therapy in the class C patients, Barcelona patients, and further larger studies are needed to confirm all this data. Thank you.
Thank you, Professor Pupa, your lecture and experience. And I think we are